Hello, everyone. Welcome. My name is Terry Lakowski, and I'm the Program Director of Support Group Services for Us Too. I'll be your host tonight. We're happy to be together again for this evening, and through the amazing world of technology, we have almost 400 people registered, and people are joining us from all over the country. And as many of you have watched many of these in our series, you know, this is probably one of my favorite parts is we have folks joining us from all over the country, including the United States, Canada, Finland, Jordan, the United Kingdom, Nigeria, Philippines, India, and the Bahamas. This webinar tonight is going to be the fifth and final session of the S2 2021 series, What is Right for Me in My Prostate Cancer Treatment? Tonight's discussion will be on genetics and genomics and is sponsored by Pfizer Astellas, AstraZeneca, and eReach at the University of Pennsylvania. One of the challenges men face in selecting a treatment plan for prostate cancer is that there is no single standard of care that applies to every situation. With this series, we hope that Us Too has helped patients and their caregivers understand their options and has provided some information to help each person help make the best choice for his own unique circumstances. Through our support group network and close to over 100 virtual support groups, our newsletters, educational materials, webinars, and other events, Us Too will help transform resignation into determination and fear into hope. Really quickly, I just want to go over a few housekeeping items for tonight. So one really important thing is please use the Q&A for your questions, not the chat box. The chat box is more for fun. If you have general comments, you know, throughout the presentation, that'd be great. But if you have actual questions for the doctors, please post them in the Q&A. And then please also understand that we've had hundreds of questions that have come in ahead of time, and we have shared those questions with the doctors. So they'll be incorporating many of your questions into their presentation. So we really do appreciate those questions that come in ahead of time so they can just add those into their presentations. And then we'll do our best throughout the webinar tonight to answer some of your questions that are coming in through the Q&A. So I also want to say that the information and opinions expressed in this presentation are not recommendations by Us Too or for any medical treatment, product, service, or course of action. So be sure to consult your doctor about your specific situation before embarking on any health program. So tonight, I am so honored to have some of the top doctors in their field with us tonight. Backed by popular demand, we're going to be welcoming Dr. Heather Cheng. Dr. Heather Cheng is an associate professor in medicine at the University of Washington and in the Division of Clinical Research at the professor in medicine at the University of Washington and in the Division of Clinical Research at the Fred Hutch Cancer Research Center. Heather is the director of the Prostate Cancer Genetics Clinic at the Seattle Cancer Care Alliance. She is a medical oncologist specializing in genitourinary cancers with a clinical and translational research focus on the germline and somatic genetics of prostate cancer. Next up, we're really excited to have Dr. Brittany Szymaniak with us this evening. Dr. Szymaniak is a genetic counselor in the urology department at Northwestern Medicine and has expertise in GU and GI related hereditary cancer syndromes. She is passionate about increasing provider and patient awareness of prostate cancer genetics and the role of genetic counselors. She is a member of the NCCN High Risk Assessment Colorectal Panel, which focuses on hereditary colorectal cancer and I'm probably saying this wrong, I apologize, polyposis syndromes. Dr. Szymaniak has been highly involved in the development of Northwestern's early detection on genetics in the EDGE EDGE program, which aims to provide coordinated and comprehensive care to individuals with hereditary cancer syndromes. As part of this program, Dr. Szymaniak is the lead genetic counselor for the EDGE BRCA BRCA Men's Health Clinic, as well as the EDGE VHL Clinic. She also provides counseling for male infertility patients and is working with a retinal specialist to develop a genetics program within the ophthalmology department. In addition to her appointment in urology, she has a faculty appointment with Northwestern University's graduate program in genetic counseling, serving as a lecturer and thesis advisor. So, and I'm super excited because tonight we are really fortunate to actually have a moderator. We have Dr. Veda Giri joining us this evening. Veda Giri is professor in medical oncology, cancer biology, and urology at Sidney Kimmel Cancer Center at Thomas Jefferson University. She is a medical oncologist with specialization in clinical cancer genetics. Dr. Giri is director at Cancer Risk Assessment and Clinical Cancer Genetics at Thomas Jefferson University, where she leads an integrated and comprehensive effort in inherited cancer risk assessment and conducts studies focused on genetic evaluation of cancer risk. She has focused interest in developing the field of genetic counseling and genetic testing for inherited prostate cancer. Dr. Giri started the first men's genetic risk clinic in the US in 2014, focused on genetic evaluation of inherited prostate cancer in the setting of multidisciplinary care. Dr. Giri currently serves on several national committees, including the NIH, PDQ Cancer Genetics Editorial Board, ASCO Evidence-Based Medicine Committee, ASCO Cancer Care Delivery Council, and ASCO Health Equity and Outcomes Committee, and ASCO Coverage and Reimbursement Steering Committee, contributing expertise in cancer risk assessment and genetics at the national level. So, we have some amazing doctors here tonight, and I'm really so excited to get started. So I'm going to hand it over to our moderator, Dr. Giri. I'm handing it over to you.
Hello, such a pleasure to be here. Thank you, Terry. Thank you to us too for organizing this incredible event and webinar and series. And it's a pleasure to be here today as the moderator for this event. And I am delighted to present the first speaker, who is Dr. Heather Cheng. She will be speaking on genetic and genomic testing in prostate cancer, clinical implications, and new directions.
Thank you so much. It's a pleasure to be here. I think some of you may have heard this. Let me just make sure I can share my slides. Can you all see my slides okay? I can't actually in this view, I can only see myself, so I can't tell if people are, can someone let me know if they can see my slides? Yes, perfect. Okay, great. All right. Let's see here. There's my disclosures. And this is just a quick overview of how we're going to split up our time together this evening. So I'm going to start by talking a little bit about definitions, terms, disease states, an introduction to prostate cancer, which most of you probably don't know or don't need, but maybe a few of you in the audience would benefit from an overview. And it also is helpful to think about where are the biggest changes in terms of how genetics and genomics can actually currently change management, and then looking ahead to where do we hope it will in the future. So some of this, it doesn't broadly apply to all different stages, but I hope by the end of this time, we'll be able to give you an appreciation of where we're headed. I'll talk a little bit about genetic testing and genomic testing, how it's changed, some of the exciting new developments, but the nuances that come with it. And then tumor and somatic testing, there was already a question in the chat about that. I'll talk briefly about clinical trials, and I apologize in advance because this field, even since last year, has exploded in such a way that we can't go through even a substantial fraction of the trials because they have just increased, and that's really exciting. We can provide you some resources for where to look, but we won't be able to go through all the different trials, except to say that there are many, and it's exciting times. So I'm going to start with this slide, which is what we talk about when we talk about genetics, and this is just an intro to say there is inherited DNA, what we refer to frequently as germline genetic testing. So testing of DNA that essentially represents your master blueprints that each of us individually have and make us unique. We inherit half from our mother and half from our father. And this master blueprint set occurs in all cells of our body. And certain genetic variants and mutations that we might inherit from one of our parents may be linked with a higher risk of cancer. Doesn't mean everybody who has these risk factors develop cancer, but may increase the risk in a manner in which we might manage their screening differently for cancer, or we might think about risk reduction or prevention strategies. Tests that Dr. Szymaniak is going to talk further about of the inherited DNA include blood, saliva, and skin. And it's important to recognize that this fundamental master blueprint DNA does not change over time. So we can assess that at any time in the process. If somebody doesn't yet have cancer, if somebody has low risk cancer and is on active surveillance, if they have recurrent cancer, or if they have metastatic cancer, it doesn't matter. We can test at any point in that spectrum. In contrast, there's cancer-specific DNA, which is sometimes referred to as genomic DNA or somatic DNA, or increasingly we're thinking about it as biomarker testing because it is used in order to make treatment decision-making for how we manage prostate cancer. I'm going to sort of talk about that again in a moment, but I would think about this as the working manual. So you have the master blueprints, and then you have your working copy. And this working copy might be the one that you keep in your back pocket, like recipes, right? There's a master recipe and there's a recipe that you scribble your notes on, and that one might have additional detail. And these are private to the cancer cells. They start out as the master blueprints, but then they develop additional mutations or alterations. And those additional mutations that are private to the cancer are not passed on to children or shared with siblings or other relatives. In the case of cancer-specific DNA, we must test the cancer or the cancer tissue, either the cells or the tissue, in order to glean information that is about the cancer. And so that is one sort of difference. We usually do this with a biopsy or looking at the prostate tissue once it's been removed surgically. But in some cases, and increasingly, we are able to assess mutations that are from the cancer in the blood. Now, obviously, this is really exciting because it's much less invasive than a needle biopsy. However, there are some nuances, and I'll go over that in a minute or later on in the talk. And the test methods are evolving quite rapidly, I'll say, and even since last year, probably. And then tumor can also evolve over time as it develops resistance or gets exposed to treatments, and then may evolve to escape certain treatments. And so that's something that's also important. So the cancer-specific mutations are subject to a variety of factors, whereas the germline inherited fundamental DNA is much more static. Okay, so another way of thinking about this is the master blueprints of the car. There's a lot of cars in the lot. We know kind of what the make and model is. You can see maybe they differ a little bit in their color, but they're kind of recognizable. They're all tidy and sort of, and on the right side is a scene from Mad Max, where the cars have really been kind of tailored in a way that makes them much more fierce and aggressive and maybe poorly behaved. So that's one way of thinking about it. So this actually calls to attention a white paper that was just published, and actually Dr. Giri and I are both on this, and this sort of highlights the fact that we acknowledge as a field that this terminology or the vocabulary, the words that we use, can be confusing. And so there is a consistent or a need for consistent terms in when we talk about some of these concepts. And so the preferred consensus terms for genetic testing for inherited cancer risk refers also to the purpose of the testing. The purpose of the testing in that situation is really to understand whether there's a risk of cancer that has been inherited and whether that risk might be shared with other relatives. And so that follows the expertise of Dr. Szymaniak, so she'll talk more about that. But you can see from the table that there's other ways in which we refer to that type of testing. And then there is biomarker testing, which is really driven and aimed at how do we decide what the best treatment is for the patient. So it's a slightly different question, but they are related. And I will highlight the fact that I think even though germline mutations are typically for genetic testing for inherited cancer risk, they are now also considered biomarker testing, because some of our newest drugs, which I'll talk about in a moment, patients can become eligible if they have an identified germline mutation that is sufficient for candidacy for those drugs. They don't actually need to necessarily have tumor sequencing, although many times that is also happening. So here's another way of looking at it. Some of you may have seen this before. This is the, in my mind, how I think about it as a Venn diagram. On the left is the blue circle is inherited germline genetic testing, primarily for inherited cancer risk. And on the right side is the biomarker testing, also considered genomic testing, and really sort of primarily focused on treatment decision making. And there's this large area that sort of seems like it's getting bigger in the middle, where we're trying to do both, and we're trying to do it well, and we're learning how to do it together. Also importantly, and we don't want to forget about, when there is an inherited cancer risk mutation, then we want to acknowledge the fact that there may be risk for other cancers. So we may want to also not just be thinking about prostate cancer, but perhaps other cancers like possibly pancreatic cancer or male breast cancer. So there are situations where we want to sort of remember those as well. And of course, remembering the family, if we think there are other members of the family may have risk, that they may be able to be proactive about if they wish. Okay, so this is Prostate Cancer Disease States 101. This is just a way to organize how we think about different stages of prostate cancer. So this is a spectrum from patients who, and I'll show this again, it's just a kind of way to think about the disease spectrum. So there are people who may be at risk for prostate cancer who do not yet have a diagnosis of prostate cancer. Maybe they have a risk factor like an inherited BRCA2 mutation or an inherited HOXP13 mutation, and they may wish to screen for cancer to detect it earlier because they're at higher risk. So I put that in sort of the dotted line. And then some men may have a diagnosis of prostate cancer, but now increasingly, if we believe that that cancer is not going to be life-threatening, then perhaps it is better overall for that man's health to do active surveillance and avoid more aggressive treatments that may cause more side effects in that person whose cancer is not as aggressive. Whereas other people who have more life-threatening prostate cancer or more aggressive potential may be more appropriate for definitive treatments such as surgery or radiation with or without androgen deprivation therapy or otherwise testosterone suppression. And then at the right-hand side is the advanced disease setting, where either we have evidence that cancer has recurred after surgery or radiation. Let's say the PSA is rising, but we can't see anything on scans yet, although our scan technology has gotten better, as many of you may know or already heard about. And then also, if people have been on testosterone suppression, that over time, as men live longer with prostate cancer, they can develop even more virulent disease, or more late-stage disease, I should say, called metastatic hormone-resistant prostate cancer. So this is the disease spectrum. And I bring this up because, as I was mentioning earlier, there are areas where there's current changes in management, and there's areas where there are clinical trials where we're still learning, is this the right thing to do now? We think it is, but we have to formally prove it with clinical trials. So sometimes people will ask, well, I have this knowledge of this mutation, how does this affect my management? And the answer is, it really depends where you are on the spectrum, the degree to which we can comment on or have a discussion about how, and it may be more or less depending on where you are or where a patient is. So as a medical oncologist, I and many of you in the audience, probably, and maybe all of you, are interested in this idea of precision treatment opportunities. I think about it most frequently in advanced prostate cancer, because many of my patients in the medical oncology clinic are in that situation. And we know from a study that was done in 2015, 2016, funded by Stanford Cancer, that about 20% or more of metastatic or advanced, the kind of farthest right end of the spectrum, prostate cancers have defects in DNA repair genes that are really critical for the fidelity of the DNA over time. So when there's a lot of errors in the system because there's not a robust DNA repair, then cancers essentially have a higher, faster evolutionary process, and they can develop resistance and become more aggressive and kind of escape our best treatments more quickly. So 20% of them have defects in DNA repair in genes such as BRCA2, ATM, BRCA1, and these DNA repair defects can be or are now treatment biomarkers. In other words, they predict when we see a BRCA2 mutation, that predicts response or a higher likelihood of response to PARP inhibitors, which I'll talk about in a minute, and platinum chemotherapy. And so this is really exciting because it's essentially like a new toolbox for patients, or an additional toolbox for patients who have certain mutations. And this is one of the reasons why this is really important to think about, especially with patients who have advanced disease. In 10% of men, so 20% of them are in the cancers, and in 10% of them, they're in that group where they had inherited that mutation or inherited component. For example, they have an inherited BRCA2 alteration, and that would be important both for their treatment as well as important information for their relatives, their blood relatives. Okay, so this pie chart just tells you of those 10% or almost 12% in this series from 2016, and published in the New England Journal of Medicine, that the majority of those mutations, these are all the different genes that can be mutated in the DNA repair pathway. The majority of them are in BRCA2. And that's kind of good news because that's the one where we are more confident that PARP inhibitors may be effective against cancers with BRCA2 alterations. But there is a lot of other genes, and I'll talk about throughout the rest of the talk. These are really important. We recognize they're important. They're enriched in the metastatic disease setting, but we don't know as much about any one of them as we do about BRCA2. So BRCA2 is kind of the example I'll talk about, but I also want to acknowledge that we have a lot more to learn, and these are not all the same. So we already have a clue. We already have clues for this, and many of you may be familiar with this already, but for example, ATM does not look like it predicts in the same fashion as BRCA2. We still know it's really important, but we don't know, there's much more to learn about it. And maybe we can, as we learn more about its biology, we'll be able to tailor the treatment even further. So right now we're sort of lumping this group of genes together, but over time, as we get more numbers of patients and have more experience using some of these drugs, then we'll be able to parse them out individually and be even more precise than we are now. Two other important points. One is, of these patients who had alterations in their tumors that are inherited or are germline, not all of them had a family history of cancer. So while in the past family history was a criteria and remains a criteria, it's necessary, but is not sufficient for finding all the patients who may have these mutations that have important treatment and family implications. So we don't want to limit ourselves only by testing people who have a family history. Now the NCCN criteria also include testing all men with metastatic disease and now high-risk localized disease. So people who have Gleason 8 and 9 disease are also candidates for germline genetic testing, and we'll talk more about that. These also, as I mentioned, represent known or suspected autosomal dominant cancer predisposition. So having a mutation in a relative would potentially increase the risk of cancer, and that might be really important information for the relative. This slide is, I think I won't spend a lot of time on this because I kind of alluded to this already, but BRCA2 is the gene that we know the most about. It is still associated with family history of breast and ovarian cancer. So this highlights the importance of asking not just about family history of prostate cancer, but other cancers, including breast, ovarian, and other cancers. And then BRCA1 and then ATM I alluded to also. And then MSH2 and MSH6 are part of a different kind of family of DNA repair genes that is associated with another hereditary cancer syndrome called Lynch syndrome that Dr. Szymaniak will probably also talk more about. But this is also an important pair or family of genes and has been associated with family history of colon cancer, endometrial cancer, association with ductal histology, although there's, again, more to learn about those, and then Gleason pattern 5 as well. This slide is just to highlight the fact that a lot of what the early data was in the metastatic setting, the 12% from the New England Journal of Medicine paper on this top row, and then another study from Spain, Dr. Castro showed 16% prevalence in this population, and then 9.4 in the hormone sensitive population. But this recent paper in 2021 in European Urology out of the Dana-Farber group showed that there's 9.5% of patients with intermediate and high risk localized disease. So this is supporting evidence that men with high-risk localized disease, in other words, if it's not spread, it's still in the prostate, but it's Gleason's 8, 9, or 10, that those men should also be offered based on their personal history of prostate cancer germline genetic testing. So that's new data, and I think supports some of the efforts that are already underway. Okay, so DNA repair deficiency, I talked about this a little earlier. There's a number of different families of DNA repair deficiency. Here's homologous recombination, which is the family that includes BRCA2, BRCA1, PALB2, ATM, and then mismatch repair deficiency, which is over here, which includes MSH2, MLH1, MSH6. And the point here is that these are associated with different cancer syndromes and with different treatments. So PARP inhibitors, rucaparib and olaparib have now been FDA approved in advanced prostate cancer in the setting of many of these genes, mutations. And then platinum, which includes carboplatin, is also an agent that would be in the toolbox for patients whose cancers may be associated with alterations in these genes. And then immune checkpoint inhibitors such as pembrolizumab, also called Keytruda, would be an option, potential option for patients who had mismatch repair high, which is in their tumor, which I know is kind of technical, but really is another sort of molecular feature that is associated with deficiency of this other DNA repair family. On the top half of this is really the expanding toolbox, systemic toolbox, expanding options for patients with advanced prostate cancer. So people, again, at that disease, when you think about that disease spectrum, the people who have advanced disease, these are all agents, and this toolbox keeps growing. So testosterone, abiraterone, enzalutamide, I won't go through all of them, but most recently, as many of you may have heard, lutetium 177, PSMA 617, we're really excited about. I put it in parentheses because it's not yet FDA approved, but there has been a phase 3 positive trial that was reported. So that's exciting. So this is the toolbox for people who, all patients with advanced disease. This is not, it does not require having a biomarker or any particular mutation. But if you have a mutation, there's this special toolbox for prostate cancers that are associated with specific mutations or biomarkers. So those are the ones I just talked about: pembrolizumab, rucaparib, which is approved for BRCA1 and BRCA2 alterations, olaparib, which actually has a larger list of genes that are inclusive in its drug label. Again, we don't know as much about all of these genes as we do about BRCA2. So as time goes forward, we'll need to learn more about those. And then carboplatin. Okay, so I also wanted to make the point here that we have, even before we recognize this, as we recognize the importance of BRCA2 and the related family of DNA repair genes in advanced prostate cancer, we recognize that in people who don't yet have prostate cancer, these represent prostate cancer risk genes. In other words, if a son of one of my patients inherits a BRCA2 mutation and he doesn't have cancer yet, he may be at a much higher risk of prostate cancer. And the data in the past, or the historic data, suggests that the cancers will be more aggressive. And so this may sound like unfortunate news, but I would argue that this is an opportunity, and that if we look forward and we learn more about the biology of these specific cancers, we've already seen that we now have better drugs for these cancers that have these mutations. And so as we learn more and understand their weaknesses, tailor the treatments to address that weakness, then the outcomes may actually become better. And we saw this in breast cancer for triple negative, or for HER2 positive breast cancer. It used to be the worst prognosis of that group, and then it became one of the better ones because we have drugs that target HER2. So this is just to say, as we learn more, we'll be able to improve what we can do. Genetic effects on cancer risk and treatment response are not equal. I'm sort of showing this in the same way. I keep saying this, I know, but hopefully it'll stick. BRCA2 mutations are relatively rare in the population. They occur in about 1 in 50 in Ashkenazi Jewish populations and 1 in 400 in the general population. And as I mentioned, if you have one of these mutations and develop prostate cancer, which is not a certainty but a possibility, then the prostate cancer may be more aggressive. And one study suggests that by 85 years of age, there's about a 60% risk of developing prostate cancer. Then there's a lot of genes in between. So I already talked about, we don't know as much about ATM. We don't know about CHEK2 as much. There's some we do know, but we need to sort of work together to learn more about these. There's definitely new options for treatment, new combination strategies, and we want to know if some of these strategies are effective if we use them earlier in the disease spectrum. Or maybe we find they're not effective and then we don't want to use them at all. Okay, so this slide is just to sort of forecast that Dr. Szymaniak is going to talk more about how we think about relatives and what we can do, and that is really important. It's just as important as the treatment implications is how can we leverage this information to help improve the outcomes for the next generation or for siblings. So I think that's really important. This is talking about the importance of cascade testing, and we really need our genetic counselors and our patients, and to be thinking about this, and our physicians, and we're all of us working together on this panel, working on efforts to try to improve our ability to do this as a field. This is going back to prostate cancer disease states 101. And I think this is a segue. Hang on. This is just let me see here. Okay, yeah. So this is to say, as I mentioned, the PARP inhibitors currently are approved in this green box here, the sort of most advanced disease state. We currently have clinical trials for molecular subtypes in these two boxes, biochemical recurrence and hormone sensitive metastatic disease. And then they're either open or more are in development in these red, in this active surveillance, definitive treatment, and early detection. And I'll briefly mention later on 2 early detection studies. But this is really to showcase the fact that now, even compared to last year, we have many more trials either open or in development along this entire disease spectrum that may be informed by germline or somatic testing. There were a number of questions in the pre-registration question panel that addressed this question of biomarkers and metastatic versus circulating tumor DNA. So I added a few slides here. At the top is just the disease spectrum. And then here is just to remind you what I said at the beginning, which is that germline DNA, fundamental blueprint DNA, does not change over time. So we can test this DNA at any point in the spectrum, whether somebody has advanced disease, metastatic disease, or whether they don't even yet have prostate cancer. Any point in the spectrum, they can have germline genetic testing. If they have prostate cancer, actually, I drew this red line. The red line should start here, but this reflects disease burden. So when the PSA is going up, it may mean that there's cancer. And then let's say somebody has their prostate removed and then their PSA goes down. And then for some people, it may be the case that their PSA later on starts going up. And this suggests that there's still residual cancer. And then maybe there's treatments that are effective. And then, you can sort of see for people that live a really long time with prostate cancer, this might be their PSA trajectory. One of the important things to recognize is when in that spectrum is the best time to test tumor. So here's sort of a time frame. There's no absolute right answer at this point, but here are some of the things we're thinking about as a field. When you have a biopsy for diagnosis, that's great. That's important for establishing the Gleason score, so helping decide what the appropriate localized treatment is. Let's say somebody has their prostate surgically removed. You can go back to this tissue and do sequencing on it. And one question is, well, is that the best tissue? Or should you get a metastatic biopsy? And part of the answer may lie in what's this time frame? Is this time frame 2 years, or is this time frame 12 years? If it's 12 years, then this is going to be really old, and maybe it's not the best tissue to test. But if it's a couple years, then maybe you could use that and then not need to put a needle in and do a new biopsy. And studies actually, and I'll show some data in, or I'll refer to a couple studies in a moment, that there are some cases where certain critical mutations are identified in the prostate at the time of prostate surgery and remain relevant. So They may be important for treatment decision making, and we can see them fairly early on. There's also, as I alluded to, and many of you are aware, metastatic or circulating tumor cells, which can be measured in the blood, and circulating tumor DNA, which are tests that some of you may have heard of, like, and actually specifically called out, like Guardant, for example, or circulating tumor DNA can be I think Foundation has one. There's a number of them on the market. And those are ways to try to assess the tumor DNA from the blood. Now, I think at the beginning, one of the important points is timing and tissue is critical. So if you're checking the blood and your PSA is here, it's low, then the yield of your blood test to look for tumor DNA is going to be low because your cancer is quiet. The best time to think about circulating tumor DNA is if you can't safely do a metastatic biopsy and your cancer is actually growing. That kind of makes intuitive sense, but sometimes we forget about this. I've seen lots of patients who get Guardant or they get ctDNA and their PSA is undetectable. And I would say that's not really a good time to do it, because the likelihood of having a red herring and a false positive of something that you find that's completely unrelated to your prostate cancer is very high. So timing matters when you're talking about tumor assessments. So tumor testing depends far more on timing and tissue than germline testing is. It's one advantage of germline testing is that it is consistent throughout the disease spectrum, but there are many nuances to both. Dr. Szymaniak is going to talk further about some of the nuances of germline testing. I'll spend a couple more slides talking about nuances of biomarker and genomic testing. So here's sort of a cartoon from a nice review this year from Dr. Alex Wyatt's group in University of British Columbia. So this is a sort of cartoon of saying, here is somebody who has primary prostate cancer, and as sort of designated as this little yellow dot. We can put a needle in and we can get a tissue sample. This is sort of a cartoon of a slide. And then maybe later on they get treatment, but the cancer may grow, and then they have metastatic disease, and maybe the cancer's in more than one place. Let's say it's in a rib, it's in a bone, a couple of places. You could get a biopsy of that, or perhaps you can do a blood test and assess the DNA here in the blood and not have to do the biopsy. So that's what I was just talking about. The advantages of plasma ctDNA are potentially ease of, it's much easier, it's a blood test. And you may be able to serially sample. It's much easier to get more time points than it is when you have to do a metastatic biopsy. There are some disadvantages, and I sort of alluded to one, and whereas there may just not be any cancer there. So you may be finding mutations that have nothing to do with the cancer if there's no cancer in the blood sample. You can also have interference from something called CHIP, which I'll talk about more in a moment. But essentially what that means is there can be interference of mutations that exist that are unrelated to the cancer. And so that's important. So here's some additional nuances of genomic testing. So these are tests of the cancer, drivers versus passengers. So this is also really important. I see Foundation one or reports issued, and there's a whole, maybe there's 4, maybe there's 5, maybe there's 2 mutations that are, and it's not clear from the reports always which one is the most important from a treatment standpoint. Sometimes we don't know, but sometimes we might, if we're sort of thinking about this a lot, or the real, some of the diagnostic pathologists, molecular pathologists have a sense of this, and people think about this a lot. Certain mutations are much more likely to be driver mutations. For example, BRCA2, if we see that, we are much more suspicious because we know the pattern, and we know that that mutation is more likely to drive the biology of the cancer rather than be a passenger, which is there, but it's not critical. Whether it's there or not may not matter to the biology of the cancer. So if it's a passenger mutation, then treatment implications are not going to be as robust because it doesn't, it's kind of neutral, so to speak. So the next sort of, one of the important things that we as a field need to learn about is which mutations are drivers and which ones are passengers. So that's one. I will say, so number 2 is primary prostatectomy versus metastatic biopsy. So actually Dr. Schweitzer from our institution and our colleagues did this really nice paper basically showing that for some genes, mutations, namely homologous recombination DNA repair gene mutations like BRCA2. For key driver mutations, a BRCA2 key driver mutation, the radical prostatectomy sample may be sufficient in most cases. They compared the prostatectomy with metastatic biopsies later and then ctDNA later, and found that the mutations that mattered later could be seen early on. So in many cases, if it has not been 12 years, for example, the prostate, surgically removed prostate cancer may be sufficient for some of the more important questions of is there a BRCA2 mutation? But we still have a lot more to learn about this. So the other thing that I sort of alluded to, but is obvious and has now been also published, now in hindsight it's obvious, is the yield of blood-based tests is better if the PSA is rising. So basically, you know, if your PSA is undetectable and you're doing ctDNA, your yield is going to be really low, or you're going to get a false positive, something that's unrelated to your prostate cancer. And the reason for this is that there can be bystander blood cells, like white blood cells that are in your blood, right? They're part of the environment of your blood. They can also develop mutations. Sometimes those mutations are something called clonal hematopoiesis of uncertain potential or indeterminate potential. They don't really have to do with prostate cancer, but they can also be some of the same mutation that we sometimes see in prostate cancer. So that can be a source of interference where you can see a mutation, but it has nothing to do with the cancer. So that's a very important limitation. And labs need to be sort of mindful and thinking about it. And if they're thinking about it, they can control and sort of do corrections for it. But if they're not thinking about it, then you can actually get a lot of false positives where people think they might have, let's say, a BRCA2 mutation in their prostate cancer, and they actually do have a BRCA2 mutation, but it's not from the prostate cancer, it's from an unrelated cell. So in those patients, PARP inhibitor and platinum chemotherapy would not be likely to be helpful. Because a mutation is there, but it's not related to the cancer. So some take-home points. Germline mutations are really important. I spent more time today talking a little bit about the thematic mutations, but germline mutations are extremely important. If you do them, you may miss tumor-only mutations. And if you do tumor-only mutations, you will also, despite all the nuances, in some cases will miss in the inherited component. So going back to that Venn diagram that I showed you, they are both important, they're complementary, but they each have different purposes. So that's really important. They are not sufficient to substitute for each other. Prostatectomy samples, if they are recent and or metastatic biopsies at this point would still be preferred when they're safe and feasible to assess for treatment decision making, but circulating tumor DNA and circulating tumor cells are absolutely things that we are excited about, and in the right setting can really be helpful. So we're still learning about them, but I think at this point, if we can get actual tissue, it's probably preferred. I think I gave you hopefully a sense of the fact that the trial portfolios are really now much more expansive and involve this disease spectrum. This is just, to highlight for those of you who aren't already familiar with clinicaltrials.gov, because I wasn't able to talk about all the trials. This is the nice place to start looking for some of those, many of those new exciting treatments. Okay, so I'm going to wrap up this section with some take-home points. Number one is genetic testing for inherited genetic testing and biomarker testing are increasingly important in prostate cancer care. I think that hopefully, if nothing else, you can appreciate that that's the case. It's really exciting time. There's rapid changes in how gene mutations, both inherited and tumor specific, affect treatment decisions and options for clinical trials. There are many ongoing clinical trials of treatments for men with mutations and who also have prostate cancer. And we have a couple and more, hopefully, of screening trials for people who have risk genes, but don't yet have prostate cancer. And we can, at the very end, talk, maybe highlight some of those trials. And then we have a number of exciting ongoing clinical trials to offer men genetic testing and counseling using a variety of new approaches, and or to partner with them to learn about their experience in doing this, because it is relatively new. We're excited about it, but we want to do it thoughtfully. We want your feedback about it. And we also want to understand long-term outcomes of those more rare variants. that is really important for everyone, for the field, for families, for advancing knowledge. And then I'll finally just say that it's really important to talk with your provider about these. Everyone's situation is a little different, and you could consider seeking guidance at centers of excellence with cancer genetics and molecular diagnostics expertise. The three of us on the panel represent all different, different areas of the country, and we each have, I think, centers of excellence. So if you feel like you're not getting enough information, ask for another opinion. I'm going to stop there and hand it over to Dr. Szymaniak, and look forward to more questions and discussion in the panel.
Thank you very much, Dr. Cheng, for that excellent presentation. Very informative.
Right.
And it is my pleasure now, yes, absolutely, as we transition here to the next presentation, it is my pleasure to introduce Dr. Szymaniak to be speaking to us about prostate cancer genetic testing, talking to us about the nuances regarding genetic counseling, the process of genetic testing. Thank you, Dr. Szymaniak.
Excellent. Thank you so much to us two for having us here. I'm really excited. And once again, my name is Brittany, and I'm going to be talking more specifically about some of the germline aspect for this. Here are my disclosures. So I wanted to start with some information about who genetic counselors are. Most patients that I've met with and spoke with haven't necessarily met with a genetic counselor before or know what we do. So I just wanted to provide some context. So we have specialized training in medical genetics as well as psychosocial counseling. And we're approaching about 5,000 of us practicing across the country. We have to earn a master's degree in genetic counseling from an accredited program, and we have to sit for boards. So we need to be board certified through the American Board of Genetic Counseling, and we're employed in a variety of spaces. So it's not just cancer that we work in. As you see, I've listed a number of different areas, but prenatal cancer and pediatrics are historically some of the biggest areas that have employed genetic counselors, but this has expanded exponentially over the last couple of years. So what role specifically do we play in oncology? So typically, if somebody is interested in genetic testing and they're referred to a genetic counselor, you're going to be coming in, we're going to be talking about your family history, usually going over 3 generations, and doing a risk assessment, looking at those cancers that we're seeing in the family history and trying to figure out, are we actually concerned for there being an inherited explanation for the cancers that we're seeing? Do we think that there needs to be genetic testing? What genes or what syndromes are we thinking about? And kind of talking through, in the situation that we do think that there's an inherited explanation, what are those cancer risks? What does the management look like? But we also do a psychosocial assessment. So not every individual is going to be at the right stage kind of in their process or in their treatment to actually undergo testing. Maybe this isn't information that somebody wants at this particular point in time. And the testing is completely voluntary. So it's never necessary that somebody undergo genetic testing, especially if it's not the right time for them. We talk about possible results. We facilitate the decision-making process, making sure that you're getting the information that you need from the testing. We go over all of the other considerations, so insurance, cost, turnaround time. And then when results come in, we're going over this information, we're interpreting it with you in the context of the family history. If there's positive results, we'll coordinate follow-up care and help facilitate testing for other family members. So I just wanted to give you a very broad overview of some of the things that you might expect if you are referred to a genetic counselor, or to just give you some context if you're interested in scheduling an appointment. So Dr. Cheng very nicely set the stage for this. So I wanted to reiterate some of the aspects that came up in her talk. So about 70% of all cancers that we see are going to be sporadic. So these are cancers that have unfortunately just happened by random chance. And we think that this has maybe something to do with environmental components, maybe different lifestyle factors, but this is kind of our general cancer population risk level that we think about with sporadic cancers. We can see that there's familial cancer risk. And so this is about 20% of cancers. So this is the situation where we see clusterings of cancer in the family. We can see it with prostate. We can also see it with things like colon colon cancer or breast cancer for women. In these situations, we think it's actually multiple genes that are kind of all working together to increase that risk, and possibly some environmental component. So we think that the risk is going to be increased beyond general population, but not necessarily increased in all degrees to what we see with hereditary risk, which makes up about 5 to 10% of cancers. So it's more rare that we see that there's a single gene that's really driving some of those cancers that we see. And just to also come back to kind of some of these differences between a somatic or germline change. So somatic, just like Dr. Cheng mentioned, this is going to be an acquired change. It's going to be specific to a particular tissue, specific to a cancer developing. These are associated with sporadic cancers and not things that can be passed down. Whereas a germline mutation, this is something that is going to be inherited from a parent. It's going to be present in essentially every cell of your body and is something that can be passed down to children. So another way of kind of thinking about this is that we all have 2 copies of our genes. We get one from mom, one from dad. Normally, but in normal cells, sometimes we can have these acquired genetic changes that will happen that over time, maybe with different insults to us through aging process, other environmental factors, things like radiation, these cells can start to grow out of control because of these acquired genetic changes, and we can have a tumor developing. But in the setting of hereditary cancer, somebody's actually already starting out with a genetic change in one of these genes. So it's putting them one step closer to actually developing a tumor. So it, just like Dr. Cheng mentioned, this doesn't guarantee that somebody's going to develop a cancer, but we know that that risk is going to be higher because they're starting out already further down the line to developing a tumor. But other genetic changes still need to happen kind of as part of that tumor development. And just to reiterate, some of the somatic testing that goes on, really a lot of the goal of that is to help identify therapeutic targets based on that specific genetic profile of that tumor. So usually something that is done across different types of tumor tissue, so not just something that's specific to prostate cancer. And is often done at different stages, and there's different types of tests. They all kind of evaluate different things. They're not all necessarily looking at the same genes and assessing for the same type of genetic profile. But ultimately, a lot of it comes back down to how are we specifying the diagnosis? Do we think there are certain treatments that are available? And in some situations, how aggressive or what's the likelihood that we think that there might be recurrence down the line? So if we think about those categories of cancer that I talked about before, how does that apply to prostate cancer? So the vast majority of prostate cancer is going to be sporadic. We know, unfortunately, about 1 in 8 to 1 in 9 men over the course of their lifetime will develop prostate cancer, just as common as breast cancer for women. We can see that familial component though. So we know that if you have a close relative, a father or a brother, this can actually increase your risk to develop prostate cancer because of that shared genetics between you. And it's really only about 5 to maybe up to 12% of the time that we see that there's a hereditary cause for prostate cancer. Specifically, if somebody has metastatic disease, we think that there's a higher possibility or probability of actually finding an inherited cause, approaching kind of 12% versus maybe 5 to 6% for somebody that has localized disease. So where did kind of all of this start? So we've been doing genetic testing for hereditary conditions for over 30 years. 2 of the genes that we've been doing testing for the longest are the BRCA genes, just like Dr. Cheng mentioned, BRCA1 and BRCA2. So we have a lot of information about this in the context of breast cancer and ovarian cancer risk for women, but it really is probably within the last 5 to 10 years that we've come to have a better appreciation of these genes' role in prostate cancer as well as other genes. And it wasn't until really 2018 that we first started with introducing testing for metastatic prostate cancer because of those studies that Dr. Cheng outlined. So there was more research going on into those genetic causes in the situation of metastatic disease. So then we started to expand that criteria. And since 2018, it's definitely evolved, and I'll come back to that a little bit. But there's still a lot to learn. And so even though we're doing testing for prostate cancer, this is still very much an evolving field. And thinking about, generally speaking, some of the signs that we can see for hereditary cancer syndromes, just not necessarily specific to prostate, but when I'm evaluating families, I'm looking for early ages of diagnosis. So do we see individuals that are diagnosed with specific cancers younger than we would typically expect? because somebody's already born with a change in one of these genes, putting them closer to tumor development. So we can see cancers happening younger. Are there multiple generations that are affected with cancer? Are there multiple primary cancers in a single person? So are we maybe seeing bilateral cancer for breast or bilateral cancer for kidney? Are we seeing related cancers across the family? So are we seeing multiple generations of things like breast and ovarian cancer? Are we seeing rare types of tumors, things like male breast cancer? And I specified some other cancers here. But also we take into account ancestry, because just like Dr. Cheng mentioned, there's certain populations like the Jewish population that we can actually see that there's an increased incidence of certain hereditary conditions. So if we think about criteria for hereditary prostate cancer, so we have these national guidelines, these NCCN guidelines, that there's two main components. Because of the longstanding history of testing for the BRCA genes, the NCCN breast, ovarian, and pancreas are actually one of the primary criteria that we use and different insurance companies will use. But across NCCN breast, ovarian, and pancreas, as well as prostate, there are two primary considerations that if an individual has metastatic disease, high risk or very high risk disease, they qualify for discussion about genetic testing. If somebody has prostate cancer, regardless of the risk group, then we can actually, and in addition to Ashkenazi Jewish ancestry, we can see that they also would qualify for genetic testing because of that risk for that population. And there's other specific criteria that we think about when it comes to other family history. So are there histories of things like breast, ovarian, and pancreas that might indicate or suggest us things like BRCA mutations, versus the NCCN prostate is a little bit more general with emphasis on prostate cancer. So are we seeing multiple generations of prostate cancer, especially if people are diagnosed young or have metastatic disease, but are more broad in the criteria that they use for family history information for them. So if somebody has metastatic disease, high risk or very high risk disease, they're going to qualify for testing. And as Heather mentioned, as Dr. Cheng mentioned, the biggest contributor is going to be BRCA2, which is associated with hereditary breast and ovarian cancer syndrome. Certainly a misnomer. There are other cancers that we can see with this, with prostate cancer being one, but we can also see things like male breast cancer, pancreas cancer, melanoma. And with BRCA2, we can actually see that there's an earlier age of onset in some situations, and can actually see more aggressive disease. And there's other genes that Dr. Cheng mentioned, things like Lynch syndrome. So this is going to be a condition that's primarily associated with early onset colon and uterine cancer, usually under age 50. It's a newer association that we have with Lynch syndrome and prostate cancer. So the information isn't as well defined as what we have with BRCA2, but it's kind of an emerging area. But also because of the implications that we can have with treatment, this is also one of the reasons why we're doing more testing related to these genes, even though some of the information is a little bit more limited. But there's other genes like HOXB13, which this is kind of a single gene cause for familial prostate cancer. So we can see multiple generations and this clustering of prostate cancer in families. But this particular gene, at least at this point in time, doesn't have association with any other cancers. So we don't necessarily expect to see other cancers in the family, and we don't necessarily expect to see risks for women. So it's really predominantly prostate cancer. But there's other DNA damage repair genes listed below, things that Dr. Cheng also talked about, that are more newly associated with prostate cancer, but like talking about with the Lynch syndrome genes and like talking about with the BRCA genes, there are other cancers that are actually more established for some of these genes. And it's actually just newer that we're seeing some of this association with prostate cancer. So as I kind of mentioned, this is still kind of a newer field. So there's not as necessarily clearly defined prostate cancer risks for all of these genes. We don't really have a specific idea of how what the magnitude of risk is going to be if we think it's just overall risk that's increased, or if we think it's younger age of onset or potentially more aggressive disease. There's still a lot of studies going on about this. And we don't necessarily have clearly defined screening recommendations for individuals that are unaffected. So if there's a positive result in the family that maybe a son tests positive for, we might not have any recommendations to change for prostate cancer outside of what we would recommend for family history. And I'll come back to that as well. But there may not be clearly defined risks for other cancers necessarily. So with all of this, there's still important information that can be garnered with this testing, because there could be risk for other cancers, and this could be information for other family members as well, especially if we think about risk for women in the context of things like BRCA mutations, but there are those treatment considerations as well. So how is genetic testing actually done? What does this entail? So we can actually look at DNA from blood, from a cheek swab, from a saliva sample. It's going to be the same DNA that we're looking at. There's just stipulations with things like cheek swabs and saliva samples for contamination that we don't necessarily have that risk with blood. So we're actually reading through these genes, looking for essentially spelling errors that are happening, or if there's extra or missing information that's present in that gene, comparing it to our reference to figure out, is there anything different from what we're seeing from our reference? And usually can take about 3 to 4 weeks to get results back. So let's delve into those possible results. So there's maybe 3.5 is what I'll call it here. One possibility is a positive result. So this is a harmful or pathogenic change that's been identified in this gene that we know is going to be associated with an increased risk for specific types of cancer. So depending on that gene, there might be changes in the medical management that we would have recommended, and we would think about doing testing for other family members. But it's possible the test results can come back negative, meaning that there wasn't any harmful genetic changes that were identified in any of these genes, but we still go back to recommendations based on personal and family history. But there may also be other family members that we need to think about doing testing for them because maybe there's still an unresolved suspicious history of cancer. A true negative is in the context that there's a known genetic mutation in the family and an individual is undergoing testing for that genetic change. And if they are negative, they're what we would call a true negative. So there's some stipulations for this. Being a true negative doesn't always take somebody completely off the hook when it comes to screening. So we'll talk about that a little bit more. And then there's inconclusive results. So this is also really important. So we can find genetic changes that are different from our reference, but we don't know for sure if this is something that can actually lead to increased cancer risk or if it's actually just normal human variation. So with these inconclusives, we essentially are going to treat them like they're negative findings until we have more information to say otherwise. There's going to be more research, more data that's going on to help the labs reclassify these findings to positive or negative. So we keep an eye on these inconclusives, but we take them with a grain of salt until we have more information to say otherwise. So why do we actually undergo genetic testing? So there's some benefits and there's certainly some limitations. So this can possibly help explain cancer history. It can inform risk for an individual for other cancers and lead to increased screening. It can may be able to help inform treatment and help determine risk for other relatives. But it doesn't always provide us an answer. More often than not, people are getting negative testing results back. In some situations, this can lead, if there's maybe a positive result, can lead to increased anxiety or guilt associated with that, especially if there's a possibility of passing things on. And sometimes this is just unwanted information. Some individuals may not want to know whether or not they're increased risk for other cancers. Possibility of uncertain results, as well as genetic discrimination, which we'll come back to. But cascade testing is really one of the hallmarks of this genetic testing process. If there's a positive result, we can then offer very targeted testing for other family members to help determine if they are at risk, with the ultimate goal being able to initiate those increased cancer screening for those individuals to either prevent a cancer from happening or identify it earlier when it's more treatable. So there's going to be different screening recommendations based on results. If testing is positive, it's going to be based on the gene as to whether or not there's maybe other cancer screenings that we would want to do for that individual outside of their prostate cancer care. But in the setting that we may have a gene that there's not actually gene-specific prostate screening that we would have for unaffected individuals, we're going to be going back to familial screening recommendations, which I'll also get to in this next bullet. So in the setting for familial risk, because we know that that exists for prostate cancer, we usually tell individuals to talk to their doctor about initiating prostate screening around age 40, or take 10 years off that diagnosis of prostate cancer for that close relative. So even in the setting of negative testing, there's still possibly information that or recommendations that can be made. But even in the setting of a positive result, we still may be going back to those family recommendations. So genetic discrimination. So there is a federal law. It doesn't come up often outside of the context of actually doing genetic testing. So it's called GINA, the Genetic Information Non-Discrimination Act. This is completely separate from the Affordable Care Act and protects individuals from having genetic testing information used against them when it comes to things like health insurance and employment. There are certainly stipulations with this, depending if people are federal employees, if they work for the military, and there's certainly exceptions when it comes to things like life insurance, long-term care, or disability. There's more information that's out there, ginahelp.org. And then definitely a question that comes up all the time, insurance considerations. Coverage is going to be very variable depending on your insurance. So some insurances use our criteria. Things like Medicare have their own criteria. They're very similar to what we see for the NCCN criteria, but some insurance plans, commercial insurances, have even stricter criteria and may require things like prior authorizations. So being able to work with a genetic counselor, we can use all that information that we know about insurance plans to help come up with the best option for you. But most laboratories are going to be performing a benefits investigation, determining the estimated out-of-pocket cost, usually based on things like deductible. And a lot of labs offer a patient-free price of $250 or lower. So if we don't want to go through insurance or we know it's not going to cover it, then $250 or lower is usually what we're looking at. And you can find a genetic counselor by going to this particular website here with our National Society for Genetic Counselors. We're all over the country. We have in-person visits. We have a huge expansion of telemedicine services that's really increasing the access to all of that information and ability for patients to actually connect with a genetic counselor. So some take-home points for this. So genetic testing for prostate cancer is still very new. There's a number of different genes that have been associated with hereditary prostate, but we don't have all of the answers yet, and we're still learning a lot. And there can be treatment implications, which is why we think about doing some of this testing to begin with. But this can help explain cancer histories and inform risk for family members. And genetic counselors can help determine if testing is right for you by being able to do that risk assessment, give you a better idea. But certainly there's a need for alternative delivery models and not always meeting with a genetic counselor maybe before testing is happening, because this is going to be a way that we can increase access. We have a lot of patients that qualify for testing, and there's only so many of us. And with that, I will wrap it up and hand it back over to Dr. Cheng.
Great, thank you so much, Dr. Szymaniak. That was a wonderful presentation. I think really important for all of us to hear about, in this field of prostate cancer genetic testing and genetic counseling. Dr. Cheng here is bringing back up some slides regarding some clinical trials that we have going on. I'll speak to a couple of these, and Dr. Cheng we're going to just touch upon them because of time, and we want to leave time for questions and answers. And the slides will be available, the trial information will be made available to you. So we will get this to you. Very quickly, the TARGET study is one study that is going on. It's a national study, an East Coast to West Coast collaboration, where we are testing a web tool as a way to deliver genetic information versus genetic counseling. We know that there is a lot of volumes of patients that need to see genetic counselors, and this particular study is looking at a web tool that doctors can use in their clinics to be able to offer genetic counseling to their patients and make genetic testing more accessible. So this is available for particularly individuals who live in Pennsylvania, New Jersey, New York, and the state of Washington, where our study sites are located. Thank you for the chance to discuss this study.
Okay, so I am going to introduce Gentlemen, which is genetic testing for men with metastatic prostate cancer. This was launched in 2017, originally started in the state of Washington, is now available anywhere in the US. And this is limited to men with metastatic prostate cancer, because I think sometimes the sort of decision calculus may be that for metastatic disease, there are treatments now. So there's more that can actually occur, and maybe the sort of risk-benefit ratio is a little different. So in this study, patients can, or participants, people who are interested who have metastatic disease, can go to the web, fill out some survey information, and then they're mailed a saliva test to their home, and then they can review the results by phone with a genetic counselor, which is required if they have a mutation, and by invitation if they do not have any findings. And then there are follow-up opportunities after that, and we can also help connect them with local genetics professionals if they are not already have access to one. So there's information there for any of you who may be interested in that study. This is a new study that's sort of recently launched called PROMISE. The overall intention of this study is to find men with prostate cancer and increase access. So men can undergo saliva genetic testing online with an education module. It's not randomized like the Target study. They can do it from home. And the follow-up to it is if they have mutations of interest, or even if they don't, that they then will get follow-up newsletters to update about clinical trial opportunities that are particular to the mutations that they may have. So the goal is for long-term follow-up to try to understand these more rare variants and to just gather more information, and to partner with patients so that we can give information back that may be really important for both their treatment as well as potential opportunities for their relatives. So that is the PROMISE study. You can see the URL there. If you're interested, you can check it out. So I'll hand it over to Dr. Giri.
Yes, and this is the Progress Registry, which is a national registry that we have launched for any male who has already undergone genetic testing for prostate cancer. And the registry is enrolling up to 500 males. And the purpose of this registry is to be able to gather information about men's experience with genetic testing, genetic counseling. We know this is a relatively new field compared to genetic testing and counseling for female patients. And so we really want to be able to understand men's experience with this, their knowledge and information that they need for themselves and their families. So we're collecting this information as a survey in all online as part of participation. And we'll use this information to be able to develop resources that men and their families can use. We will also be linked in with the learning community and be able to have webinars based on the results that we're getting to be able to address the questions and concerns that men and their families may have. So the link and the website is there for progressregistry.com to be able to participate.
Okay, so the next two slides are what I had alluded to, which are opportunities for men who may be the sons or brothers of some of our patients who, or my patients actually, so I've had this situation come up now, where my patients may have a mutation and then their son or their brother has a mutation, and then we want to know, well, what can we do better for those relatives? So this is a study that actually Dr. Giri and I are both part of, which is at the National Cancer Institute in Bethesda, Maryland. It's a study aimed at men ages 30 through 70 who do not yet or do not have prostate cancer. They may be at risk for prostate cancer because of a family history or because of a known inherited cancer risk mutation. Some of them are listed there. And they are offered screening every 2 years with an MRI of the prostate, and that's covered by the study. The biopsy if the MRI is abnormal, and there is no cost for study-related tests or procedures, and they do cover travel expenses to Bethesda. So this is a really nice opportunity, and so just wanted to share that with you, and the study information with the phone number and the email contact is there. And then we also have a related study called Patrol at the University of Washington. We're currently getting it open at Texas and in Oregon. It's a similar study, but I think just understanding, if there's ways in which we can screen more attentively, understanding that, and this is a whole nother talk, but there are some limitations to PSA. And so we're also collecting urine biomarkers, blood biomarkers, in addition to imaging and MRI. And some patients can even participate in both the NCI study as well as Patrol. Here is a table that summarizes some of the study opportunities, and we'll have Terry send this out in the follow-up newsletter, so you'll have access to this information for further reference. We're just going over kind of the highlights.
Wonderful. Thank you very much. And we will be able to get that information to you. So wanted to just review that this is a really exciting field, and there's a lot of research that's going on the side of engagement with men and their families, all the way to the genetic and biologic side of things in terms of determining who may get aggressive prostate cancer or best treatments. So lots to update you on and keep you updated on as we go forward. So we've been receiving some amazing questions in our Q&A during these presentations, and also we received questions before registration as well. So we have limited time, and so we'll choose some of these questions to be able to address with Dr. Cheng and Dr. Szymaniak. One of the questions that came through during the presentations was a really great question regarding germline testing and so inherited cancer genetic testing. And could this potentially be a double-edged sword? Does it really, we heard that it can provide information for potentially identifying treatments, but what about the this double-edged sword of knowing the risks for cancer that can be identified? Could that create anxiety for men and their families? And so I'll pose this first to Dr. Szymaniak in terms of how you handle this in the genetic counseling setting regarding guiding patients through this piece of the discussion.
Yeah, that's an excellent question. And so as I kind of alluded to during my presentation, we have that type of assessment and decision-making process with our patients, and that talking through kind of what the implications would be and how they would feel about possibly having a positive result come back. Do they want to know whether or not they're actually going to be at increased risk for other patients? I have some people tell me that if they get a positive result, this is going to be debilitating information for them. They don't want to know whether or not they're going to be at an increased risk for other cancers. But I have some patients that come in and they say, something's already happened to me. I want to know as much information as possible so that I can be proactive about it. And that's really the key is, how is this information going to be useful to you? And is this going to be information that you feel like you're going to want at this particular point in time? So kind of walking patients through that process and figuring out, maybe now isn't the time for testing. And maybe we need to think about doing testing maybe a couple months down the road once somebody's had a chance to maybe wrap their head more around their diagnosis.
Dr. Cheng, I'd like your perspective on this question too, in the sense of when you see patients potentially with, say, metastatic disease or much more advanced disease, where the genetic results could actually be informative for treatment, but there is this anxiety about uncovering hereditary cancer risk. How do you approach those questions and those types of scenarios?
Yeah, I think it's as we've discussed, it's really a rapidly evolving landscape. So up until very recently, our ability to obtain somatic testing and get that covered was extremely limited. And so there was a period of time with many of the studies that we're talking about where germline is a little more feasible for men with metastatic disease, had more immediate treatment implications, and for some people it was the right decision. And so it is still a personal decision, and I would say you can't unknow the germline aspect, and it has bigger implications. I would say, though, that it seems to me that men with metastatic disease have a different frame of reference compared to people who are healthy or even who have low risk disease. So this is where you are in the disease spectrum, what your family history is, may very well inform sort of your willingness or your comfort level with proceeding. And we're all different. We want to be respectful, but we also want to, if there is a patient who wants to know and has barriers, then we want to remove those barriers for that patient. But for other people who have hesitancy, then somatic testing is much more accessible than it was even a year ago. And so I think that's going to shift over time.
And I will plug too that this has been a ongoing question in the genetic counseling field for years. So there's been a number of studies that have been done, not necessarily in the context of prostate cancer, but looking at kind of anxiety surrounding testing, especially in the breast cancer community. And a lot of studies have shown that there might be initial increase in anxiety when results come back, but that is something that subsides over time. So there's actually good data that's out there that still definitely needs to be explored in the prostate cancer community specifically, but at least we have evidence to show in other situations that there can be anxiety, but it's something that can subside over time.
Absolutely. And I think it definitely points to the need to meet with a genetic counselor who can actually help patients talk through this and arrive at the right decision for them and their families for testing. So another really important question that came through was regarding the genetic information that we may have from diverse populations, for example, among African American men or men of African descent. How much, given that prostate cancer is at higher prevalence in this population, how much do we know about what could be the genetic cause versus environmental or other reasons for prostate cancer development? And this is definitely an area of ongoing research and much needed research. But Dr. Cheng, I was wondering about your thoughts about some of the information about engaging African-American males in genetic testing and what is known perhaps at this point in time about the genetic or inherited basis for prostate cancer in this population.
Yeah, I think it is still early days. I think the field as a whole has a lot of work to do to sort of partner with patients, and part of it is in the context of a lot of the other sort of things that have happened in medicine over time that have been unfortunate with respect to sort of enrollment or not enrollment, lack of consent in using, data or, I think lack of trust. Things like the Tuskegee experiments really have really hampered some of these opportunities. I think that we have to engage better. We do need, in order to avoid making the health disparities worse, we do need to find a way to overcome and start discussions and really figure out how we can do better. Because one of the things, or one of the major things, is that in all of the studies that we have, there is an underrepresentation or less representation in this data and an overrepresentation in the real world. So there's already an information gap that means that we're missing a lot of the important information and opportunities to answer the questions that you're kind of asking, which are important ones. That said, we know that BRCA2 mutations occur in Black men. We also know that because there's less representation, and you can, both of you could probably speak to this also, because of that reduced representation, the likelihood of an uncertain result is higher because there simply isn't as much data. So that needs to be addressed as well. I actually have some research with, and I'm happy to talk about it later or off, in a later forum, to help reclassify variants that are of unknown significance in families that have a high representation of cancer, and they look like they're a BRCA2 family. And one of my patients actually did that, and he is Black and he has the same mutation. It sounds like that Beyonce's dad has, but it's a common mutation in the Black population, and it is a pathogenic variant. But until recently, it wasn't classified as such in most of the labs. And so that's an example of, we do need to sort of engage, and there's a lot more really critical work that needs to be done so that we don't increase the disparities in knowledge and in what we can do to help men have a better outcome with their prostate cancer.
Absolutely. Dr. Szymaniak, your perspective on this?
Yeah, I think, and I've been listening to a lot of different talks recently about prostate cancer in the Black community and how do we help build up that trust. And a lot of it comes down to having relationships with providers that these men can trust. So can you talk to this provider about the family history? Can you have that relationship that maybe they're going to refer you to a provider for genetic counseling, or talk to you about how to coordinate testing? Because I think just like you were saying, Dr. Cheng, is that we know that there's an increased risk for African-American men or Black men to develop prostate cancer, but we don't really know, are we looking at the same type of genetic changes in this community? Are we looking at different genetic changes? There's just not enough representation in the data to really say one way or the other. But I think in listening to a lot of different presentations and talks, that a lot of it is coming down to access and availability of care that's driving a lot of these disparities, and that a lot of it may not actually be as much of a genetic component as we think it is. So there's still a lot more to learn.
Absolutely. I know in our Philadelphia region, we have a couple of grant-funded research projects that are going on to address this specifically from a community level, community awareness level for African-American males for genetic testing of prostate cancer, helping them navigate the healthcare system, in terms of getting access to genetic counseling. And then more research is coming forward as far as, how do we engage further to get genetic testing done? This comes to a lot of the healthcare system issues, insurance coverage for those that are underinsured. How do we manage all of this? So it takes everybody, it takes all heads coming together with, with combined approaches that I think hopefully will make progress here. So, and then we just have 1 or 2 minutes left. And so I just wanted to end by, there was several questions about men that actually are prostate cancer survivors who were questioning, would they be someone who should consider genetic testing? Do the guidelines support genetic testing for them? And Dr. Cheng, what would you say about that as far as, eligibility for genetic testing for many, many thousands of prostate cancer survivors in this country?
Yeah, I think it's a really interesting question. I think, hopefully the question, for some people, the question comes from a survivorship perspective. And I think if there is a family, particularly if there's a strong family history and a personal family history or personal history of prostate cancer, I would really then think more about that, especially if somebody's already kind of interested, because of the potential knowledge that can be gained, not just for their families, but also for their own screening. Because, as we've talked about, sometimes these, the risk genes can lead to risk of other cancers. And there may be actually, I can think of a couple examples in my patient panel where there's multiple cancers and survivorship from multiple cancers in a positive way. So I think that I wouldn't certainly not discourage somebody. Now, that said, if it was a personal history of prostate cancer that's cured with no family history, then the relative yield may be lower. I still would say if somebody's really interested and motivated, then sure. But, whether or not it's likely to change, that maybe a little less than somebody, but who has, but I think that I wouldn't discourage it. I don't know, Dr. Szymaniak, if you would say anything else to that, or.
No, I actually agree, because I think this is kind of, the way that I approach my practice is that if somebody's interested in talking about their family history and is interested in getting an assessment about what the risk could be, I'm more than happy to talk to that individual, because maybe actually the best case scenario is they come in and we look at the family history and I say, actually, I'm not worried. This doesn't look like there's a hereditary cause in the cancer for the cancers in the family. Maybe this individual doesn't meet criteria because we think that there's actually going to be a low yield. And sometimes that can be a very reassuring conversation to have. So I think if there's questions or concerns about the family history, I think it's always worthwhile to reach out to somebody to help kind of figure out what that next step might need to be.
Absolutely. And it really becomes an individual process. So, I think that's one of the benefits, is to have the individual conversations with a genetic specialist. Well, we've come to the end of our time, and I really want to thank Dr. Cheng and Dr. Szymaniak for wonderful, fabulous, high-level presentations that were given today. And I also would like to thank Terry, us too, for allowing me to moderate this session. I think this was just a wonderful, fabulous discussion, and we had such an engaging conversation. Thank you both. And I will turn it back over to Terry for closing remarks.
And thank you, Dr. Giri.
Yes, thank you.
Hey everyone, this is one I really wish that I really miss in person, because this is when we would all be giving you all a standing ovation. That was fabulous. Thanks so much, everyone. Put in your thanks in the chat. because that's always fun to sign off like that. But excellent presentation. We're so honored to have the three of you here. I also want to make sure we thank our sponsors one more time: Pfizer, Astellas, AstraZeneca, the eReach, University of Pennsylvania. And I also want to say special thanks to the S2 team, specifically Tim, James, Tracy, and Rebecca, for all the work that goes on behind the scenes to put these webinars together. So be sure to watch for that follow-up email next week with all the information about those studies that they were talking about. That will be there along with your recording of this event. You will all receive the recording of the event. So please stay safe and sound, everyone. Thank you so much. You guys all have a really good night.
Good night.
Bye-bye.
Good night.
Take
Thanks,
care.
everybody.
Bye-bye.